So we can start. We can start. Right. So this lecture, we will discuss about the ventilations and some related mechanism of respiration. So basically, the first lecture very short. That was the mechanics of ventilations, but there are some other related things related to ventilation. Those we will discuss here, and these are the ILOs. You can read them leisurely and try to understand. Especially lung volumes is very important. Gas composition change, compliance of the lungs, and surfactants. Those are important areas of the today's lecture. And relevancy, yes, actually, as I mentioned in the first lecture, previous lecture, with the artificial ventilation, oxygen treatment, most of things that we discussed today, it's important, especially with the anesthesia and related to artificial ventilation, patient connected to a ventilator. Right. So start with the lung volumes. In the cardiovascular system, probably you remember we talk about the stroke volume, cardiac output, end diastolic volume, like those volumes. Those volumes are related to function of the heart. Similarly, we for the lung, functions of the lung. So basically for the ventilation, we have similar volumes. Tidal volume, basically amount of air that will we inspirate or expirate with each breathing, right? In the normal breathing without extra effort. So it's like stroke volume. In the stroke volume, you remember volume of blood we push out from each ventricle per one cycle. So tidal volume also same with one cycle, one respiration. So what's the volume that we put out, or what's the volume we will take out, right? With the each respiratory cycle, we will take this volume into the lungs and we remove this volume out, right? In this diagram, it's easy to explain if we see this as a respiratory cycle, right? And this axis is volume, and this is the time for which each cycle this volume we will take, and this volume we will take out, right? So some amount of air we will take out with quiet breathing. I mean, in the resting, like you and me now, some volume we will take out and same volume we will, take in and take out. So that is the tidal volume, right? So in this diagram, so this is the tidal volume, that this volume we will take it out and take in and out. Right. So, but if you put extra effort, right? If we put extra effort, we can take more than that, right? Basically, we can inspirate with the effort more than that. Like we can get the deep breaths, the maximum inspiration. So with the maximum inspiration, some additional volume like this, we can take in, right? So that is we call inspiratory reserve volume. We can inspirate some reserve volume, additional volume we can inspirate with effort, right? Something like that, right? Get deep breath, right? So that is the inspiratory reserve volume. The same way, we can put out additional air from the lung, right? We can put out. We can expirate additional air. So we can take normal breathing, and if you want, we can put extra air from the lung. So that is inspiratory reserve volume, right? So we have normally tidal volume, normally resting, normal breathing. But additional inspiration and additional expiration is possible, right? So those are, we call inspiratory reserve volume and expiratory reserve volume, right? So if we want, we can get a very deep inspiration and keep that the lungs, and we can expirate all of them with expiratory effort, right? So if we do that, we can get extra inspiration plus extra expiration. This whole volume we can actually put out, right? We can get a deep inspiration and we can put back, that mean expirate with a deep effort. So basically the whole this volume we can keep out and send out with whole volume. That's we call tidal volume, right? So tidal volume is this whole volume. Sorry, that we call vital capacity. So, right. So this is the vital capacity. Tidal volume is this one. So vital capacity is a maximum volume with extra effort we can remove and empty whole lung if we remove vital capacity, right? And empty mean we have still some air in the lungs that we cannot empty. Whichever effort we put to expirate, this volume we cannot remove. They are there. Therefore, we call it a residual volume. Residual. Probably you remember residual mean something remain, something deposit that we cannot remove. So residual volume, we cannot do anything. They are there, right? So about 2 liter residual volume is there, 2 liter or more than 1 liter residual volumes there, and they are there, right? So if I repeat again, we have tidal volume, this volume, and we have inspiratory reserve volume, we have expiratory reserve volume, and we have this vital capacity of collection of all these 3 volumes we can call as a vital capacity, right? Vital capacity is the maximum volume we can remove. We can empty this volume, but still this volume we cannot do anything and residual volume is there, right? So alveolar contain always residual volume. Even with the maximum effort, residual volume we cannot remove, right? So actually, using instrument, we can measure tidal volume, right? We can measure vital capacity, this volume, right? But residual volume, of course, we can measure, but it's not easy, right? Because that's the one remain inside the lungs, and we cannot do much for that, right? So you need to remember this tidal volume, inspiratory reserve volume, expiratory reserve volume, residual volume, vital capacity. You need to remember. And there's something called inspiratory capacity and functional residual volume. You can understand them, but you need to remember this, this 1, 2, 3, 4, 5. These things you need to remember, right? So in healthy adult, tidal volume is about 500 milliliter, right? So it's a half liter volume. Always we take it in and take it out, right? So this, try to remember this value also, and residual value is more than liter, considerably volume is there always, right? Right, so we will erase them. Right, so here I explain this term. Something we need to erase. And this, I already explained vital capacity. Vital capacity, as I mentioned earlier, it's we get a deep inspiration and expirate with the maximum effort. That is the vital capacity. But in practice, sometimes we use forced vital capacity. That means if let's say if I uh, if I want to remove whole vital capacity, this capacity we can remove, but with effort also we can do that, right? When we try to remove the whole lung, when we try to empty whole lungs forcefully, we call force vital capacity. So that means when we measure vital capacity, we don't do it forcefully, but when we measure force vital capacity, we will do it forcefully. That means with uh, with with higher rate, right? So we have vital capacity and force vital capacity. The value wise, they are very close, but they are two things. Then we have force expiratory volume 1. That means when we remove vital capacity, if the easy way to draw something like this. So let's say this is the uh, rate and this is the time, right? Let's say we consider inspiration in this cycle. We fill the lungs. This is with the time, with the rate. We fill the lungs with this air, and then we expirate, right? Because it's other side, the flow is in the opposite side. We remove that, expirate. So we take into the air into the lung and take out, right? So when we consider vital capacity, we consider whole time wise until we finish all the air. But we can measure volume in per second. Somewhere here per second. This is whole time. I mean, we will let it to flow continuously without time limit. But same time we can limit in the per second. Per second. Per second mean within per second, what is the volume came out, right? So fraction of vital capacity, that is amount that came out, the volume that coming in per second, right? So that means after that also some volume will come. So that we call force expiratory volume 1, this one. Force expiratory volume 1, actually force vital capacity, but we will measure only until per second. පළවෙනි තප්පරේ විතරයි ගන්න. So forcefully we remove air, but volume that came out only per second we measure. Right. So which one should be high as a volume? This one or this one? කොයි එකද volume එකක් විදියට වැඩි වෙන්න ඕනේ කොයි එකද? Which one is high? FEC or FEV1? Yes? Not clear. As a volume, which one is high? FEC or FEV1? Sorry?
FVC.
FEC, yes. FEC should be high because we will let person to continue to maintain airflow considerable period. But here we take only volume in the per second, right? Somewhere here, if this is time, we will take up to here, but this is the total. So volume wise, here less volume. So therefore, we can talk about the ratio, right? FV1 to FVC ratio, right? That means what is the volume of air that came out in per second compared to total volume came out. So usually this value is about 80%, right? In the healthy adult, it's roughly 80%. That means within per second, 80% of the air volume will come out. That means 20% will come after per second. So let's say this is 20%. and this is 80% as a volume, right? As a volume. So these are practically important values when as you learn in the cardiovascular medicine. Stroke volume is important, cardiac output is important, ejection fraction is important to clinically assess the heart. So to clinically assess the lungs, vital capacity is important, but forced vital capacity is important. FVV1 is important, and this ratio is important, right? So these are important values when we clinically try to diagnose things, try to assess the lung function. These are important values, right? So I will use some other diagram later to describe them. Right. So in addition to that, there's some other thing. We can measure the rate. So in all these, we measure the volume, milliliters. But here we can do the rate, that means volume per time. As example, we can ask patient to get a deep breath and forcefully expirate. Forcefully expirate and measure the rate of the airflow. That means when we measure the rate of the airflow, milliliter per time, millimeter per second, or millimeter minute or second. So this is a rate, peak expiratory flow rate. That is the maximum flow rate one can achieve, right? Get the deep breath and ask to expirate and measure the rate of the airflow. දන්නවනේ රේට් එක මයින්න පුළුවන්. දැන් අපි දුවනකොට වේගෙ මයින්නා වගේ airflow, we can measure the speed of the airflow. That is peak expiratory flow rate. But these are all volume, just milliliter, without considering the time. But here we consider time, but it's still a volume in per second. At the end of the per second, this is volume. But here purely a rate, right? That also important clinically. Right. So this is the diagram that I drew there earlier. This is actually this is volume. Of course, we can consider it as a time because time take to. This axis is volume and this axis is the flow rate or flow, right? And you can see this is inspiration. In inspiration, we can consider a flow it's to one direction. Flow is moving into the lungs. This is expiration. Flow is moving opposite direction. That is why curve is upside in the other side, right? So this is inspiration, this is expiration, and this is volume. And you can see this is, if this is the maximum volume we can achieve, like 5.5 liters. Sorry. Yes. Yeah, I think yes, this axis is liters. Yes, this is liter, 5.5 liters. That is the maximum volume that we can exhale or inhale with a great effort. That include tidal volume, inspiratory reserve volume, expiratory reserve volume, everything. This is inspiration. Then we expirate, flow is opposite side. So this is the volume come out and come to a peak and then gradually go down. And within per second, it will be something like this. After per second also, some volume will come out. This measurement we call spirometry. Using special instrument, we can get this graph, right? The spirometry basically measure the volume and direction and time, and those things we measure. In some disease, this is normal shape. This shape might vary in certain disease. And there is a special practical for spirometry, so I will not explain here the shape. And this is normal shape, but these are some abnormal shape in different conditions. And if there is a problem in the airway, like bronchial asthma, right? Probably you learned something of bronchial asthma already. If there is a problem in the airway narrowing, bronchial asthma, expiration is difficult. So this curve will be not like this. It will go down like this and like this, right? So this is something like this or something like this when there's a airway obstruction. So spirometry will be a practical. You will learn more about that later. Right. So there are two types of disease: restrictive lung disease. Restrictive lung disease mean if let's say this is airway and then branches, then further branches, and finally connect to a alveoli, right? So airway connected to lung. So there are two types of disease: obstructive airway disease. So basically airway obstruction, right? So if there is a airway obstruction, the main problem about the expiratory rate, and from alveoli, air cannot be moved quickly because of the airway narrowing. Obstruction or narrowing, with that we call obstructive airway disease, right? Well-known one is asthma. Asthma is a airway problem. So we call obstructive airway disease asthma and chronic obstructive airway disease, and so there are some airways. Then we have restrictive lung disease. Problem is in the alveoli, right? In restrictive lung disease, alveoli cannot expand the way we want, right? Alveoli cannot expand because maybe this alveolar membrane is thick and contains some unwanted tissue like fibros, or maybe water. Pulmonary edema, we call pulmonary edema, water and the fiber deposition of tissue will prevent expansion of the alveoli. Alveoli cannot expand adequately. So they call restrictive lung disease. Restrictive for the expansion, right? Restrictive lung disease or restrictive alveolar disease. Then other way is a obstructive airway disease. So remember, this is in airway problem, not alveoli. Obstructive airway disease. So obstructive airway disease is bronchial asthma, and of course there are some other example, restrictive airway disease, lung fibrosis, and some other condition. Right. So tell me that if there is a restriction, so I mentioned about the forced vital capacity, right? Expiratory, force expiratory volume 1, force expiratory volume 1, right? Force vital capacity, force expiratory volume 1, amount coming out in the minute, right? So in the, if there is a airway obstruction, that means air will not easily come out, right? So remember, if there's obstruction, biggest problem for the expiration, not for the inspiration, because as you know, inspiration, we put extra effort, expiratory muscle, air will enter into the lungs, but expiration is the problem because expiration is a passive process. Of course, we can put an effort, but expiration is a passive process. So in the obstructive airway disease, which one? This first one and second one. In the obstructive airway disease, which one will affect more?
Second one.
Sorry?
Second one.
Second one. Why? Yes, you are correct. Why?
It's difficult to explain
Yes.
because of the obstructions. I can't.
Yes, correct. You are correct. Because of the obstruction, we cannot remove it. It takes time. Removal will take time. So that's the problem, right? Removal will take time. That means it will not easy to remove, right? So in the obstructive airway disease, this will reduce. In the restrictive lung disease, if there is a restriction here, which one will affect more? If there's a restriction, lung alveolar cannot expand. Lungs alveolar cannot expand. That means restriction. Which one will affect? First one or second one? මොකද කියන්නේ? Yes? First one. Yes, because lungs cannot expand and ability of the alveoli to retain air will be limited. Right? So this one will affect more in the restrictive lung disease. So when this one is low, probably it's a restrictive lung disease. If this one is low, probably it's obstructive airway disease. Right? So this ratio, which ratio? Force expiratory volume 1 to force vital capacity. This ratio will be low in obstructive airway disease because this one is low. Force expiratory volume 1, right? Ratio will be low in obstructive airway disease because since this one is low. When this one is low, ratio will be low, isn't it? Right? So usually, roughly we can say it 80% if it will below 80% in the obstructive airway disease. But restrictive lung disease, since this one is also reduced, probably ratio will be normal, low, even it can be high. Right? So that these two, to differentiate these two, this ratio and these values are important. Right? Remember that. Right? In the practical, you will learn more. There will be practical on spirometry. In spirometry, we can get these values and we should be able to roughly differentiate these two types of conditions. Right. Right. So now we will move to something about the gas composition. Right. So I hope you have some idea about the partial pressure. What is partial pressure? The advanced physics. What the partial pressure can? Yes, physics. What the partial pressure සිංහලෙන් කියන්නේ?
ආංශික පීඩන.
Yes. What does that mean? ඒ කියන්නේ මොකද්ද? සිංහලෙන් හරි කියන්නකෝ. ඉගෙන ගත්ත එක physics.
Sir, pressure of a one particular gas in a gas mixture?
Yes, very good. So in what is the pressure in the atmospheric? What is the atmospheric pressure in the sea level?
760 millimeters.
Yeah, 700 and 760 millimeter
Mercury millimeter.
Mercury millimeter, right? So that is the atmospheric pressure, right? So that's the total pressure. So in this total pressure, we have different component of gases, and therefore we can talk about the partial pressure. And what is the oxygen composition of the atmospheric pressure in gas composition as a percentage, roughly? Oxygen
22.
Yeah, let's say 20, 21 or 20%. So In the outside air, partial pressure of oxygen is roughly this value, right? So it's 176 and 1/5 of that, right? And partial pressure of carbon dioxide, this nitrogen is very high, and oxygen, of course, depend on the humidity. So this is the composition of air mixture outside the world, right? So that is the gas composition we will take in. We will take in that composition and we will try to inhale that composition, right? So we will try to inhale this composition. Okay. So when this composition, let's say this is the composition in the outside. When this composition go through the airway to alveoli, and then this is the composition in the alveoli. Basically, this is the composition of the residual air. As I mentioned, in the alveoli, always there is some amount of gas that we cannot remove. So tidal volume come and mix with the residual volume and come and go, right? And here you can see oxygen, partial pressure of oxygen is about 104. Here it's 159 or 160, and here it's a 104. Partial pressure of oxygen reduce. Why? What can be the reason? Partial pressure oxygen adu nei.
There is some air in alveoli already with a low partial pressure of oxygen.
Yes, very good. So there is always some sort of mixing of gas, right? So before it go to the alveoli, gas will mix with the on the way also. We call trachea, bronchi, bronchioles, and some air there. So that gas contain less oxygen. So gas mixing of gas with airway is there. And of course, some gas in the residual volume contain low oxygen. So the gas coming from outside will mix with that gas. That is one thing. Yes, good. Any other reason? When you see this, you can see some other reason.
Dissolve water.
Sorry?
Make more water.
Yes, exactly. So on the way from nose to alveoli, we add water because it's a watery medium. Water vapor will add, and you can see composition of water increase. Here, partial pressure of water is 47. Here it's a very, very, very low, 4 outside. Of course, depend on humidity, that might be. So water will add on the airway. So when we come to nose from to alveoli, water will add to the air. So mixing of gas, adding of water will alter the composition of the air in the alveoli. So therefore, when it comes to alveoli, oxygen composition is 104. Outside is 160 or 59. Right. So then the purpose of alveoli. So what's the purpose of alveoli? What's the purpose of alveoli? Yeah. Yeah, it's a simple question. Don't think too much. Why we need alveoli? What's the purpose of alveoli?
Exchange gas.
Yes, exactly. Exchange gas. Right? So this oxygen should enter into the blood in the alveoli, and carbon dioxide should come out from the blood in the alveoli. So this oxygen will equilibrate with the blood in the capillary, pulmonary capillary, and oxygen will add. And in the blood, that means arterial or the blood that coming out from the lungs, that is basically blood in the pulmonary veins, right? Right, blood in the pulmonary veins. This is the partial pressure of oxygen in the blood in the pulmonary vein. So here it's a arterial blood because it will finally go to the heart and come to the artery, systemic artery. That's why it's a arterial blood, right? So blood in the pulmonary veins, partial pressure is, oxygen partial pressure is 97. Here it's 104. Some reduction because there are reasons for that. It's not 100, even though this is slightly above the 100, right? Right? Because oxygen will add to that. The same way, you should understand partial pressure of oxygen in the blood in the pulmonary artery. That means blood that coming from the right side of the heart, from the pulmonary artery, is contain oxygen partial pressure is about 40, because that is deoxygenated blood coming from systemic venous blood coming from the body. This is venous blood, less oxygen. They will come to the heart, and through the pulmonary artery, it will come to the pulmonary capillary. So this 40, partial pressure of oxygen is 40. Try to equilibrate with alveolar partial pressure is 104. And finally, we get the partial pressure of 97. That's what happened to the oxygen partial pressure. Since we add oxygen. Carbon dioxide is opposite. So pulmonary artery carbon dioxide is 46. And so this carbon dioxide will diffuse out. And here partial pressure of carbon dioxide is 40. And this is 46. And in the pulmonary vein, partial pressure is 40. So here 46, it will be 40 here. Right? So I want to highlight few things. Partial pressure gradients of oxygen, here 104 and here 40. So we have high partial pressure gradients for oxygen. From 100 to 40. Gradient is about 60. But for carbon dioxide, partial pressure gradient is, you can see 46, the pulmonary artery, and alveoli is 40. Low gradient. But still, carbon dioxide can go and remove from the blood, and carbon dioxide will be low here. Right? So, low gradient is low, oxygen gradient is high. Right? So, this, you should have some idea about the especially partial pressure in the alveoli and partial pressure of oxygen in alveoli, partial pressure of oxygen in pulmonary capillary, and finally arterial blood. Right? And I want to highlight few things. Here we say P capital A O2. P capital A O2. When we use capital A, that means alveoli. Here you can see P simple A O2. When we use simple A, that means partial pressure in the arterial partial pressure of oxygen. Here arterial partial pressure, when we simple A, capital A means alveolar partial pressure. Sometimes you might see these symbols in the diagrams and the books. You might confuse why it's a capital A and why it's simple A. Capital A is always alveoli. Simple A means arterial. Partial pressure of oxygen in the artery, partial pressure of oxygen in the alveoli. That you need to remember. Right. So, we will erase them. Right. So, gas composition, I already explained, dry air. This is the composition of the external layer, and we will add water, and we will we will add and remove carbon dioxide and oxygen. And so there is a partial pressure change of the gases. And so the same thing in different diagram. So here you can see this is partial pressure of carbon dioxide. This is partial pressure of oxygen. In the lung, it's about 46 or something. And its oxygen is 100 or 106. And so this is partial pressure oxygen outside. Partial pressure reduced when it comes to the lungs. Further reduced when it comes to the artery. I mean oxygen. And further reduced when it comes to the tissue. Tissue, blood, lungs. Partial pressure of carbon dioxide high in the tissue and slightly reduced when it comes to the lungs and reduced in the air. So you can see for the carbon dioxide, there's a gradient from outside to out, from the tissue to outside. For the oxygen, there's a gradient from outside, that means environment or outside air to tissue. So that's why how oxygen go in and carbon dioxide go out, that partial pressure gradients is important. Right. So before I go further, if you have any questions, now it's about 40 minutes, you can ask about this these things, gas composition and these values. You can ask if you have any questions about these values and the gas composition change from alveolar to blood. You can ask. Monad tino nang hano. Oh, I know it's sleepy time after lunch. If something you can ask. Yeah, if something is not, yes.
Why carbon dioxide partial pressure is reduced when it comes to tissue level to lungs? Is it converted into bicarbonate and
Yes, so that you will learn about the gas transport, right? So that basically this partial pressure mean dissolve carbon dioxide and dissolve oxygen, right? When we talk about the partial pressure, it's about the dissolve gases, right? So this is this carbon dioxide, this is dissolve carbon dioxide. Oxygen also dissolve. Of course, how it carry in the blood, it bind to hemoglobin, bicarbonate, and there are things you need to understand. You will learn it later about the carbon dioxide transport and oxygen transport. But don't try to understand at that point about the bicarbonate and so on. Just try to understand the partial pressure differences. Of course, that's a very good question. So, because what are the form of carbon dioxide in the blood? What is the form of oxygen in the blood? That is something different. But partial pressure, we refer the dissolve type. Yes, any questions? Any other questions?
Sir, what is the meaning of EST in the last diagram?
Make it
No, sir, the last.
this one. EST,
अंतिम diagram के.
make it.
नहीं sir, अंतिम में තිබ්බේ.
Make it.
Okay.
EST. මොකක් වෙන්න පුළුවන්ද? That's referred to tissue. Actually, these values are estimated value. I think that's what it means, estimated value, right? Because exact value might in the tissue level might vary depend on the exercise and so on. I think it means estimated. Artery, venous. Yes.
Thank you, sir.
Okay, right. So let's, if there's no question, we can move. Right. So now I will introduce some other concept called compliance. Right. So when in the first lecture about mechanics of respiration, I mentioned about the elasticity. Elasticity is important for the elasticity of the lung is important for inspiration or expiration. Elasticity or recoil, quality of lung or alveoli is important, inspiration or expiration.
Expiration.
Expiration, yes, because lungs we get the extra effort and expand, and because of the elastic quality or recoil ability, it will compress itself, and therefore air will move out, and pressure increase, air will move out. So therefore, in the lungs, ability of this expansion, we can quantify or we can measure it. That is compliance. Compliance mean basically volume of lung expansion or volume change per pressure change, right? For a pressure change, what is the volume change? So here you can see pressure and volume. You can see when the volume pressure increase, volume increase. This is volume, this is pressure, pressure increase, volume increase, right? So when the pressure increase, volume increase. Good example is balloon. Let's say these are two alveoli, right? So let's say in these two balloons, we will put a same effort. එක්කෙනාම තමයි පුම්බුවේ. පිම්බු එක්කෙනාම එකම effort එක තමයි දැරුවේ. But finally we got two sizes. Okay. So which balloon is more elastic? More elastic. Red or අනිත් එක දම් කියලා කියමුකෝ. Which one is more elastic? We had the same effort and tried to inflate or පුම්බන්න හැදුවා. This is the final size. Which one is more elastic? More elastic කියන්නේ ඇදෙන්න අමාරුයි. නේ? Elastic ගතිය වැඩි වෙන්න. Yes, which one is more elastic or difficult to expand?
Red one.
Red one. Red one is more elastic. Probably it has more elastic fibers and difficult to expand. When we say more elastic, probably difficult to expand. But I would say something else. If the compliance is ability, volume increase per pressure in unit pressure change. Change of volume per unit pressure change. That means if we can get a more volume change for a unit pressure change, we can say it's a high compliance. So which balloon is having high compliance? Red one, no other one. High compliance.
So excuse me.
Yes.
So I have a question. What about the elasticity? Because elasticity is much more needed for the both of inspiration and the expiration, no, sir. So how is it special for the expiration only?
Okay, I will come to that later. I already explained in the previous lecture. So answer my questions here. In these two balloons, which one is have high compliance? Red one, no other one.
Other one?
Yes, other one. Yes, correct. Good. Because compliance is the volume change per unit pressure change. This one definitely had a high volume change to a pressure pressure means same effect, let's say, simple term, but this one had a less volume change, so less compliance. So in the alveoli also, we can talk about the compliance. Basically, what is the volume change for pressure change? So in sometime compliance is high in alveoli and sometime compliance is low, and but ideal compliance is important, right? So in some conditions like pulmonary fibrosis, we will get deposited more fibrous tissue, let's say more elastic tissue, and compliance reduce, low compliance. But some disease conditions, structure of the lungs will damage and fibrous tissue will be less, and for unit pressure change, lungs will expand unwantedly, where we can call high compliance. Good example is emphysema, right? So in this diagram, you can see pressure change, volume change, and this is normal what we expect when the pressure change. We can expect this type of shape, volume increase. But in fibrosis, you can see volume increase is less for the pressure increase. Make a himin tamai වැඩි වෙන්නේ. Right? Because more fibrous tissue there. So if you consider these two balloons to the alveoli, which alveoli is having, which alveoli is fibrous? Well, which one is having fibrosis? If these are two alveoli. කොයි එකද?
Red one.
Red one. Red one is having more fibrous tissue and difficult to expand. Of course, it's more elastic, but it's not good because we cannot expand, right? This normal, and emphysema, expansion is more. We cannot expand more. I mean, it already expanded. With small pressure change, it will expand more because it has less tissue and no destroy architecture of the structure of the alveoli, and they can easily expand. So this is emphysema, this is fibrosis, and this is normal curve, right? So compliance. So you should understand the concept of compliance, and in different conditions, compliance will alter. So the question you ask, elasticity is important, inspiration or expiration, right? So as I mentioned, inspiration is a active process in the resting stage. So we'll use the inspiratory muscle, diaphragm and intercostal muscle, and take breathing. But in quiet breathing, expiration is a passive process, right? So lungs, alveoli will compress itself because of this elastic quality or recoilability, right? So if the elastic ability is less in the lungs, we cannot compress them and remove air from alveoli to external world. That means expiration is difficult. If the elasticity is low, that means compliance is high, right? So that's what I explained. So in considering same thing in lung fibrosis, that means more elastic tissue there, right? If somebody get lung fibrosis, how about inspiration or taking air in? Is it easy or difficult?
Difficult.
Difficult. So it's like this balloon, difficult to expand. So finally, alveoli get less air. In lung fibrosis, finally, alveoli get less air. Okay? Less air finally. So as I mentioned earlier, if there is a lung fibrosis, forced vital capacity, of course, vital capacity as well as forced vital capacity will reduce because lungs cannot bear air and can retain air because more fibrous tissue and alveoli cannot expand, right? So, forced vital capacity will reduce in the lung fibrosis. So then inspiration is probably difficult with the lung fibrosis. In emphysema, where compliance is high, when compliance is high, how about elasticity? Elastic recoil. Huh? Like this balloon. Compliance is high, elastic recoil low, elasticity is low. So, if so, which one is difficult, inspiration or expiration?
Expiration is different.
Expiration is difficult because he cannot empty the lungs. Because less elastic and lungs are expanded, he cannot empty the lungs and more air will retain in emphysema, right? So please understand that two condition, fibrosis, emphysema, increased compliance, low compliance, and normal compliance, right? So compliance is important concept in the pulmonary physiology. Try to understand that, right? So now I am talking almost 1 hour. Do you need a break? Let's say 5-minute break. Matroka bilen. Okay. Yeah. 5 minutes. Oh, yeah. So not more than 5 minutes, right? So I will give you now for 2:42 until 2:47. So I will start at 2:47. Okay. Right. So we can start. Now, this slide's about work of breathing. Can you hear me?
Yes, sir.
Yes. So as I mentioned in the first lecture, we need to put effort during inspiration. Diaphragm, intercostal muscle will work. That means it take energy, some work. So this energy will spend about 65% to overcome the elasticity of the mainly alveoli. Because recoil ability or elastic ability, try to push and switch on the fan. So elastic recoil or elastic ability, try to compress or try to keep alveoli small, but to overcome that, we need to effort. That means overcome the elastic work or elastic recoil. About 65% of work of breathing or energy will spend that. Then airway resistance, as I mentioned earlier, airway all the way air should go to alveoli, and there is some sort of resistance in the all the way. And to overcome the airway resistance, energy, we need to spend energy. Then there's some other small amount. We need to move some inelastic tissue, and that is work of breathing. Due to some conditions, this work of breathing will increase. As example, in asthma, airway resistance increase. Right? So we need to put extra effort. In the emphysema, as I mentioned earlier, lung structure is damaged. So difficult to empty the lung. Elastic recoil is low and compliance is high. In lung fibrosis, elastic recoil is high, elastic ability is high, compliance is low. So we need to put extra effort to expand alveoli. In heart failure, congestive heart failure, pulmonary edema or fluid accumulation will take. That also make it difficult to expand the lung because of the water there. In the interstitium, there is a water in the lung. Right? Tissue level, there's water. So all this will increase work of breathing. When the work of breathing increase, we will feel as a dyspnea. Difficult of breathing. Hatiya. Husma ganna amaruyi. So that feeling we will get when the work of breathing increase. We need to put extra effort basically for the breathing. Right? Okay. Then I will go to some other important aspect of the alveoli, surfactant. Right? Surfactant, when I want to describe surfactant, probably you remember surface tension. You get the tube, and in the water level will arrange like this. In the two end, water will behave like this. Because of the surface tension. So what's the singular term for surface tension? Pushtigatati. I am showing the Tamil nice word. So probably you remember this occurrence. We call surface tension, or you learn it as a Pushtigatati in the physics. Right? So in the alveoli also, so this surface tension always try to make water molecule to attach each other. So that's why it get this shape. Right? So let's say if we have some bubble like this, and there's a water layer inside this bubble, right? Water layer. If we make it small, next stage is like this, and next stage is like this, right? Because of this surface tension, this bubble, when it come to very small, considerable size, they can collapse. Because this water molecule behave like this and come to attach each other and collapse, right? So that is due to surface tension. Surface tension. So in the alveoli also, this will occur. During inspiration, alveoli will expand, but during expiration, alveoli get small, and inside the alveoli, we have water layer. So therefore, when it gets small, they can collapse. To prevent that, inside the alveoli, there is a special chemical substance called surfactant. There is a surfactant layer in the alveoli that will reduce the surface tension and prevent collapsing of alveoli when it gets small, right? So that is the importance of surfactant in the alveoli. Right. So like this is alveoli, and of course it contains water. Inside that alveoli, we have surfactant. It's a chemical. It's a phospholipid, right? Phospholipid, tail and head arranged like this. When the alveoli gets small, it reduces the surface tension and it prevents collapsing. So that is the job of surfactant layer inside the alveoli, right? Right. So in addition to that, in addition to that, it prevents the collapsing. It prevents the development of pulmonary edema because it removes water accumulation. It prevents water accumulation and develop the pulmonary edema. Pulmonary edema mean accumulation of water inside that alveoli. So surfactant prevent collapsing of alveoli and prevent pulmonary edema. And there is a law of something called law of Laplace. Read in the Gannon or in other textbooks, you will understand this behavior of surface tension and surfactant. This is more physics, so I will not describe, but you can read about law of Laplace. Surfactant is important even from the birth, but sometime, especially if with the birth, if the birth is earlier than expected, right? So you know that it's a 10 weeks or 280 days pregnancy. So you will stay, you baby should stay roughly 280 days. But if he want to come out early, let's say 230, right, early. So if we call premature birth, then lungs are not mature and might have less surfactant, because surfactant synthesis will occur in the latter stage of the in the fetal life, because surfactant is useless early because lungs are anyway collapsed in the inside the uterus. So surfactant synthesis will occur in the latter part of the last few weeks in the fetal life, the baby. So if there is a premature birth, no surfactant in the lungs, so neonatal with premature birth, lungs can easily collapse because of this surfactant deficiency, right? And read about that. So that is a big problem. If there is a premature birth, we need to give the surfactants to them. And to prevent that, sometimes we give mother cortisol, some drugs, special drugs, that will increase the synthesis of surfactant in the fetal lungs before birth. Of course, before birth, we give cortisol to mother that will accelerate the surfactant synthesis in the lungs of the baby and might help. If not, if the lungs start to collapse, we need to give the surfactant artificially to the lungs, and we call neonatal respiratory syndrome, and read about that in the Gannon or other places or internet or somewhere. Right. That's about surfactant. In the so anything about surfactant? Any questions? Anything you want to about surfactant or surface tension? Monawat ahana tiyanawada? Right. So if not, I will move to the next thing, pulmonary macrophage, right? So in the anywhere Probably you learn in the immunology module, you learn about the macrophage, right? So remember macrophage, right? So these are large cells. They can engulf phagocytes, bacteria, or any other foreign particle. Especially in the alveoli, we have pulmonary alveolar macrophage, special type of macrophage. They when the, let's say in the alveoli or other place, when the foreign particle come to the alveoli, this macrophage activate and engulf, right? So what are the common foreign particles that come to the lungs? Dust particle, right? In the environmental pollution, with the environmental pollutants, dust and smoke particle will come to the alveoli with the air, and then macrophage will engulf and try to destroy them, right? If there is a excessive particle come to the lungs, especially in the smokers, we get excess or large amount of macrophage or pulmonary macrophage activation and get the inflammatory process. Excess macrophage activation and something we call inflammation. That might destroy the alveolar tissue. So macrophage will help to remove the unwanted fibers, but excessive action of macrophage will destroy the alveoli because of the inflammation. That will occur in the smokers and end up with the emphysema. And in the emphysema, what we'll see in the lungs is destruction of the alveoli, right? So lungs, if you get the cross section, normally we should get this type of alveolar arrangement in the lungs, but in the with the emphysema arrangement like this, destroy alveoli, right? So that is due to activation of alveolar macrophage. Probably that's what happened in the smokers. That's why they get the many problem in the alveoli, emphysema and bronchitis, and so many things, right? Because of pulmonary macrophage. Right. So some other concept is a dead space, right? So in the lungs, let's say this trachea, and then it branch, right? And then get further branch, and finally connected to alveoli. So air should come all the way. So I mean, as I mentioned, with the tidal volume is 500 milliliter. With each cycle, 500 milliliter of air enter to the airway and all the way come to the alveoli, right? So what do you think? This whole 500 milliliter will come to the alveoli with each cycle, with each inspiration? What do you think? Methane 500 milliliter enter now. We get the 500 milliliter with each cycle, each respiration, each inspiration. That's a tidal volume. So all this 500 milliliter will come to the alveoli. What do you think?
No, sir.
No. Why?
Because some of the air will be retained at the bronchioles, some all of the area.
Yes, very good. So some volume will retain here. So roughly 100 milliliter of air, 150 milliliters of air will retain here. We get only 350 to the alveoli. So with each respiratory cycle, in the resting stage, we get only 350 milliliter of air into the alveoli, and this one will retain in the airway. So that means only 350 milliliter really contribute for the gas exchange. Actually, I would remind you, this 350 collect to the residual volume, right? We have residual volume here. With each cycle, 300 milliliter will add to the residual volume and 300 milliliter remove from the residual volume. Okay? Right? So only 300 milliliter will really can contribute to the gas exchange with each cycle. So therefore, you can see that considerable volume is waste, not really contribute to the gas exchange. So this waste volume we call dead space. Actually, the volume retained in this space we call dead space, right? Dead space is due to arrangement of this airway. There are two types of dead space. Actually, this thing is anatomical dead space. But sometimes some alveoli collapse. Or some alveoli will not get blood flow. So if there's alveoli that will not get blood flow, they also will not contribute to gas exchange. So therefore, this anatomical component plus some dead space will be there in some disease condition. So therefore, we have anatomical dead space and physiological dead space also. So if we add some alveoli which not get blood flow, we call physiological dead space. So basically in the healthy adult, anatomical dead space and physiological dead space is same, but sometimes you might get the high physiological dead space because of some problem in some alveoli, right? So remember concept of dead space, something important, right? So here in this diagram, you can see this is tracheobronchial tree, that means dead space. So no gas exchange in the dead space, right? So in the physiological dead space mean there can be some alveoli without no gas, no gas exchange because of no perfusion, no blood flow. Then altogether anatomical dead space and this dead space we call physiological dead space, right? So ideally in normal healthy adult, that should be same equal. Because of the dead space, we should define some important volume. So tidal volume is, let's say, 500 milliliter, right? Tidal volume. And the respiratory rate is, let's say, 10, right? So what is the volume that really we expirate in 1 minute? 1 minute. Tidal volume 500 milliliter, respiratory rate not 100, respiratory rate is 10. So what's the volume that will take in 1 minute? Like cardiac output. Kiyada? Respiratory rate mean rate per minute. What's the volume really we get in total volume per minute?
5,000.
5,000 milliliter. 500 into 10. Right? So obviously this 5,000 milliliter will not go to the alveoli, isn't it? Right? To alveoli, this 5,000 milliliter will not go. Why? Why? Yes, why?
Because of the anatomical and physiological dead
Yes,
space.
because of the dead space. Because of the dead space, will not go. We will not get the 5,000. So actual volume that will go is 350 into 10. Right? So that volume we call alveolar minute ventilation. Alveolar minute ventilation. So that is the real volume that will go to alveoli in minute. Alveolar minute ventilation. So alveolar minute ventilation, right? It's a real volume that will contribute for the gas exchange per minute. Alveolar minute ventilation. Right? So this value is important if we ventilate a patient using artificial ventilation, because rate and volume, everything we can control, right? So let's say we keep the respiratory rate 10 and tidal volumes we can keep in the artificial ventilation 500 milliliter. But we feel that these patients getting hypoxic, not adequate oxygen in the blood. What we should do? Yes. Yes, we need to increase alveolar minute ventilation by increasing respiratory rate and probably tidal volume. Right? If we increase, let's say we keep respiratory rate 100 and we keep tidal volume 600. Right? So alveolar minute ventilation will be 600 minus 150, that is 450 into 10. Right? So that if this is the original one, it increased slightly. Right? So you can see we can do something else. Let's say we keep 500 milliliters and we increase respiratory rate to 15. Right? That is some other option. We keep 500 milliliter and respiratory rate 150. Or let's say 112. So now 350 is the volume that will go into, let's say we increase respiratory rate to 12. There also alveolar minute ventilation increase, but compared to this, you can see the problem. Right? So therefore, dead space ventilation is some important consideration when we want to monitor patient through a artificial ventilation. Right? So think about that. Right. So we'll move to the next slide. And this one, probably you have seen this, right? In the in certain places like Hikkadua, Unavatar in the coastal area, when we want to see underwater things like coral or fish, we use this type of tube, and we will just below the surface of water, we can swimming and see underwater things. If we attach this type of tube, what will happen to your dead space? This is called snorkeling tube. What will happen to dead space?
Dead space will be increased.
Dead space will increase. Alveolar minute ventilation will reduce. So the size of the tube, very important. We cannot expand the size of tube or length of the tube because that will compromise alveolar minute ventilation. Right? So it's important in attaching this type of tube. Right? So think about what happened when we attach this type of tube to the alveolar minute ventilation. Right. So now I will move to some other important consideration. Before that, if there is any questions, you can ask up to here. Right. So now I will move to the pulmonary blood flow. So up to now, I described the ventilation or air flow. Pulmonary.
Excuse me, sir.
Yes, yes.
Sorry to disturb, sir. I have a question regarding emphysema. Sir.
Yes, go ahead.
Sir, as an emphysema, the compliance is increased, sir. So then the expanding amount is more than it's actually needed.
Yes.
So is inspiration easier or harder? Like
inspiration,
does it get
inspiration. Yeah,
Yes.
theoretically, inspiration should be easier.
Yeah.
Theoretically, because inspiration we can know the elasticity theoretically. But there are some other things because already some gas trapped in the alveoli. So some amount of, I mean, residual volume increase, right? Theoretically, you can cause EC, but practically, probably it's not that so. But definitely, expiration, easy or difficult?
Difficult.
Difficult because they are trapped, yes. Okay, right.
Thank you.
So about blood flow, so I will I will describe few things about the blood flow in the lungs. So pulmonary blood flow, and we call pulmonary perfusion, right? So as you probably remember, cardiac output is 5 liters, and volume of bloods that retain in the lungs is about 500 milliliter. Right. So in the Ganon, it say 1 liter. I think it's wrong. I search in the many places. It's about 500 milliliter lungs, blood volume retained in the lungs in the one given movement. And most important thing is the pulmonary blood flow is in the low pressure system. Probably you remember in the lungs, left ventricle and connected to aorta. Aortic pressure, systolic pressure 100 to 140, diastolic pressure is around 100 or 90, can be go down. But in the pulmonary circulation, pulmonary artery, systolic pressure is about 15 to 30, you can say 20, and diastolic pressure is very low, 10, 5, like very low. So pulmonary circulation is having low pressure system compared to systemic circulation. So here, if we consider about the pulmonary artery, this is the pressure roughly. Systolic pressure is average 20, diastolic pressure is about average 5, 6. So in the pulmonary capillary, and pressure is very low. Pulmonary capillary pressure is we call hydrostatic pressure. Probably you remember systemic hydrostatic pressure. Right? What is the systemic hydrostatic pressure? In the stalling forces, arterial and venous end. What is the value? Quickly. Stalling forces, perfusion. Matakanadda? Yeah, right. Go and read. So, pulmonary capillary pressure, arterial end and venous end, very low is roughly, capillary pressure is 10 or less than 10. Actually, we call pulmonary capillary pressure is pulmonary wedge pressure, PCW. Read about the pulmonary wedge pressure and search about the internet. What does it mean, pulmonary wedge pressure? So, pulmonary circulation is in a low pressure system. So, this is alveoli and this is blood flow, pulmonary arterial end, pulmonary venous end, and so blood will, this way pulmonary blood will come, carbon dioxide will diffuse and oxygen will enter. So it's a gas exchange will take through this pulmonary blood flow, pulmonary perfusion. So pulmonary capillary pressure about 100 mercury millimeter. So stalling forces will operate here. And again, Gannon does not describe too much, but stalling pressure, the stalling forces will apply in the pulmonary capillary also. Hydrostatic pressure is this one is very low, 10 or less. And oncotic pressure same, will operate in the opposite direction. But in the lung, we have some other hydrostatic pressure because some amount of fluid in the interstitial space and very small oncotic pressure. So there's some tendency to accumulate fluid in the interstitial space in the lung. Lymphatic flow will drain that. Right? Always we should have very good lymphatic flow in the lungs because there is a tendency to accumulate some fluid in the pulmonary interstitium, interstitial space of the lung. But if this hydrostatic pressure increase, if this 10 value increase, then that will occur in the left heart failure, because left heart will not work properly, and so heart cannot get blood from the pulmonary circulation and push it back to the systemic circulation because of the left heart failure. And if so, this hydrostatic pressure will increase and pulmonary edema will develop because it will overcome the stalling forces balance. And if it over the lymphatic flow limitation, fluid will accumulate in the interstitial space. So pulmonary edema can easily develop because of this low pressure system, right? So remember that compared to systemic circulation, pulmonary circulation, easily they can get edema. Then if we get the whole lung, this hydrostatic pressure or pulmonary capillary pressure is not same throughout the lung, because as we know, lungs lungs is like this. Let's say two lungs like this, and heart is somewhere middle, right? So heart need to push blood to upper part of the lungs, which is difficult, and easy to put blood to the lower part of the lungs. Because of the gravity, it's easy to put blood to the lower part of the gravity, and it's difficult to push blood to the upper part of the lung. So top of the lung, this hydrostatic pressure is further low, and therefore blood flow to the top of the lung is difficult compared to the bottom of the lung, right? So that is very important, and some important things that we need to consider. So therefore, we get this type of things. If we divide lungs into 3 zones, the size of zones are not same. Upper zones, pulmonary arterial pressure is considerably low, right? And alveolar pressure is higher than the pulmonary arterial pressure. So therefore, difficult to flow blood through the capillaries because of the high alveolar pressure compared to pulmonary arterial pressure. In the middle zone, probably pulmonary arterial pressure is higher than that. There can be a considerable blood flow. Lower part of the lungs, pulmonary arterial pressure is high, and we can have a good blood flow only in the lower part of the lungs. Again, these 3 zones are not equal size. Probably the upper zone is very small, and so mainly perfusion or blood flow is good in the lower part and some in the middle part of the lung or middle zone of the lung because of this pressure gradient. Alveolar pressure means pressure exerted by the alveolar air to the blood vessels, because blood vessels are very, very closely associated with the alveoli, not like in other places. This alveolar pressure will compress the capillary, right? So try to understand this variation, and we can say almost no blood flow in the upper part and very good blood flow in the lower part and the middle part in between that. So this variation in the perfusion is very important for the gas section in the different part of the alveoli, right? So I will come to the perfusion again when I describe ventilation and perfusion ratio. And about control of the blood flow, one important things I need to describe. Let's say this is alveoli and this is blood vessels, right? And this is blood vessels, capillary, and blood flow is like this, right? So let's say we get a hypoxia in the interstitium and in this area. Get hypoxia. To get the hypoxia to this area, what can be the problem? Low oxygen availability in this area. What can be the reason? මේකට මේ හරිය hypoxic වෙන්න නම් low oxygen වෙන්න නම් මේ interstitium මේ tissue එකට what can be the problem? කොහේ හරි ප්‍රශ්නයක් වෙන්න ඕනේ. මොකක්ද වෙන්න පුළුවන් ප්‍රශ්නේ? මේ හරියට oxygen එන්නේ කොහෙන්ද? From where we get oxygen to this area? Is it through the blood? Or through the air? Alveolar air? Or through the ventilation?
Through the alveolar air.
Yes, through the alveolar air. So if there is a low oxygen, that means some problem in the alveolar air flow. Maybe obstruction in the alveolar, obstruction in the airway, some obstruction here. When there is obstruction, we get the hypoxia here. If there is an obstruction, is there a point to maintain blood flow here? No. Nikam blood flow just having blood flow is no point if there is an obstruction. So what happens if there is a hypoxia? This capillary will constrict. They will constrict and stop the blood flow to this area or to this alveoli, and then blood flow can diverge to some other good alveoli. So remember, if there is a hypoxia, there can be a vasoconstriction in the pulmonary blood flow to diverse that blood to some other good alveoli. Right? So that is some important aspect of control of blood flow or pulmonary blood flow. Right? Right. So its opposite changes will occur in the systemic circulation. Probably you remember in the local regulation under the cardiovascular system, in the tissue level, if there is a hypoxia, what happened to the blood vessels? In the systemic circulation, local regulation. Matakaida, auto regulation. මොකක්ද උනේ hypoxiaක් නම්? Hypoxia. Metabolic control of the local regulation. So the blood vessel dilate. Right. So then so let's say the same thing. If there is a low carbon dioxide in this area, low carbon dioxide in this tissue, what can be the problem? Low carbon dioxide. May haril carbon dioxide level is low now. Where is the problem? From where we get the carbon dioxide to this area?
By the capillary?
Yes, by the capillary. Pulmonary arterial blood. Right? So carbon dioxide should come this way. So if there's a low carbon dioxide, mean what can be the possibility? Low carbon dioxide in the alveoli, this area.
Dilatation of the capillary.
Dilatation. Low carbon dioxide. Methenta carbon dioxide in there. No carbon dioxide coming here. Or low carbon dioxide. What can be the cause? What can be the reason?
Constriction of capillary.
Constriction of the capillary. Somewhere here, some constriction. So no blood will come because of constriction and no carbon dioxide. So no point of keeping the ventilations here. So if there's a low carbon dioxide, this airway will constrict, or bronchi or bronchioles will constrict and prevent the airflow to this alveoli, and then it can divert to air to other good alveoli. Right? So that is also auto-regulation in the lungs. Low carbon dioxide and high hypoxia will do some certain changes in the capillary as well as airflow to diverse the air flow or blood flow to a good area, and that is some sort of auto-regulation, local regulation in the blood alveoli. There's something called, with the exercise, there are few things will occur in the lungs. One is that blood vessels will dilate and capillary will dilate, and more capillary which is not used normally will use, and we call recruitment of capillary, and use them and send more blood to the alveoli. Pulmonary arterial pressure will increase because cardiac output will increase. You know, when we exercise, our cardiac output will increase. Systemic circulation as well as pulmonary circulation, but that way pulmonary arterial pressure will increase, so we can maintain good perfusion of the alveoli. So by that way, total oxygen delivery can increase with these changes in the lungs with the exercise. So you can see with the exercise, perfusion can increase and ventilation also increase, because by sending more air, we can increase ventilatory respiratory rate and depth, as well as this way perfusion of the alveoli we can increase. Right. Okay. So I try to explain you perfusion of the lungs. That means blood flow. And I mentioned about the possibility of low blood flow in the upper part and high blood flow in the lower part. And before that, I will explain about the ventilation, ventilatory mechanism, gas compression, and so on. Right? So with that, we can use ventilation and perfusion P ratio. Actually, sometimes for P we use Q. Don't worry. Some books it say ventilation perfusion. For the perfusion they use Q. Right? So ventilation perfusion ratio. Right? So in the lower part of the lungs, perfusion is low or high. Perfusion is low or high, low part of the lung.
High.
High, because of the gravity, as I mentioned earlier. The same way, ventilations, if we draw a alveoli like lungs like this, right? Alveoli are more compressed in the base of the lungs at the beginning of the inspiration. Before we really start the inspiration, alveoli are compressed more in the base and more expand in the upper part of the lung. More expand here, and here more compress at the beginning of the inspiration. So when we inspirate, when we get air, because of the air more compressed, they can retain more air compared to the alveoli in the top. So at the end of the inspiration, more air will retain in this compressed alveoli. So therefore, ventilation also high in the bases. So ventilation is high, perfusion is high in the bases. So when we go up, perfusion is reduced and ventilation also reduced. Right? So as a value, ventilation increase, perfusion increase. Right? So ventilation increase and perfusion increase, if they increase isolatedly, ventilation and perfusion, not good. Here we can use this example. Here there's alveoli where we don't have ventilation here. This value is 0. So what will happen to the ratio? Make a 0 now, perfusion, we have some blood flow. Ventilation perfusion ratio get 0. VQ ratio get 0 because the upper value, that means ventilation is no ventilation, 0. Upper value, if upper value is 0 or low, VQ ratio is reduced. In some other alveoli, you can see ventilation is good, perfusion is not good, obstruction. That means this value is low. So, ventilation perfusion ratio is very high. Make a zero, make a ananta independent. So, here VQ ratio is very high, here VQ ratio is very low. Both is not good. So, you can understand this one also not good because poor perfusion. This one is not good because of poor ventilation. So, the value should be average, ideal. Ventilation perfusion ratio should be ideal. Right? So, now you can understand ventilation perfusion ratio is changing when you go up because both will reduce from top to bottom. Sorry, from bottom to top, both ventilation and perfusion reduce, but perfusion reduce more. Perfusion reduce more when you go up. This one reduce more. VP ratio, what will happen when you go from bottom to top? Ratio එකට මොකද වෙන්න ඕනේ? වැඩි වෙනවද අඩු වෙනවද? මේක වැඩියෙන් අඩු වෙනවා. දෙකම අඩු වෙනවා මේක වැඩියෙන් අඩු වෙනවා. එතකොට ratio
වැඩි වෙනවා.
Ratio increase, yes.
Increase.
Yes. Ratio will increase, but both will reduce. Ventilation perfusion ratio will increase. So that's what happened when we go from bottom to up in the lungs. This ratio will reduce, but this ratio will increase, but both values will reduce, but ratio will increase, right? So think again and we will understand that. Probably it take time to understand, but increase or decrease the ratio is not good. It should be ideal. I mean, average. Right. So therefore, as I mentioned earlier, there is a ventilation perfusion imbalance from top to bottom. So this will explain further. In the interpleural pressure is more negative in the up, that means reduce. So that will also contribute to the ventilation. Lungs can expand more in the bottom than the top. So ventilation is less in the top compared to base. Right. So same thing, ratio will be high from upper portion of the lung. So this diagram, I think I show it even in the first lecture. Here we have lung volume and pressure change, and here interpleural pressure is less negative, here more negative, that means low, and therefore this will be the volume pressure change in the top and bottom, right? And actually that is compliance. So you can see this shape is compliance. This angle is compliance, right? So compliance is not same top to bottom. You can leisurely understand this in this diagram. I think it's in the Ganon or somewhere, or previous Ganon, I think old version, but this is important concept to understand. Right. So final two things. There is something called airway closure. So I already mentioned interpleural pressure is high in the bottom. Less negative mean high. More negative mean low. Because this is related to atmospheric pressure. Right? If the atmospheric pressure is 760, when it come to 750, it's -2. When it come to 758, it's -2 or so on. So here you can see at interpleural pressure is low and here is high. Less negative mean interpleural pressure is high. Right? So in this will be high interpleural pressure can be a disadvantage in the lower part of the lungs. Because if there is a forceful inspiration, we will inspirate with extra effort. We try to increase interpleural pressure, and if we put extra effort to forceful expiration, we put an extra effort and try to empty, and this interpleural pressure can increase considerably. So I will repeat again. Usually expiration is a passive process, right? We will not put extra effort. Lung compliance or elasticity will compress the alveoli and go. But in some condition, some disease condition or exercise, we will put the extra effort for the expiration. If we put extra effort to expiration, interpleural pressure, let's say this interpleural pressure will increase, even it can increase above the atmospheric pressure. If the interpleural pressure increase atmospheric pressure, in some individual, especially elderly, this high pressure can be above the alveoli pressure or airway pressure, and airway might compress or collapse, right? Probably not alveoli collapse, not a problem, but if the airway collapse, air will trap in the alveoli. Because airway collapse in here, air cannot, in the alveolar air cannot go out. We call air trapping. Especially base of the lungs, this air trapping will occur because of the compression of this airway. If air trapping occur, that will affect the ventilation and our ventilation ability, or alveolar minute ventilation will reduce and air exchange will impaired. Again, this is due to gravity, because that is the problem in the bases of the lungs. High interpleural pressure will collapse alveoli because it's can above the atmospheric pressure, right? So in this will occur, it's something like this normal, and sometime we can collapse like this because of the external or high intraalveolar pressure. Interpleural pressure, high interpleural pressure will compress, and so air will trap in this place. That possible, right? Because of this airway trapping, in clinical practice, they use something called closing volume, because this volume will increase the residual volume because of the trapping of the air. That will not contribute to real ventilation, right? So that will increase the residual volume. We call closing capacity or closing volume, two things. And this is some problematic things in an elderly patient if this occur, right? So finally, something about the bronchial tone. Even you can read that. The bronchioles contain smooth muscle. They contain receptor, beta-2 receptor, adrenergic receptor, or acetylcholine receptor. If we stimulate beta-2 receptor, airway dilatation will occur. More air flow will establish through to the lungs. That is sympathetic. If the parasympathetic acetylcholine receptor stimulate, airway constriction will occur, and airway will be limited. And sometimes we have drugs, salbutamol to stimulate beta-2 receptor, and ipratropium and thiotropium to block the acetylcholine receptor. By blocking that, again, we will dilate the airway, right? So that's it. And so we have 5 minutes. So that's the end of the lecture. Of course, it's a lengthy 2-hour lecture. You can ask questions if there's anything. Yes, if there's anything you can ask. Okay, if not, I will stop the lecture. Okay, so Have a nice day.